Here is the tray with some perforations and some tray adhesive. So what I'm going to do is use the heavy body, and I'm going to do some border molding first. Something along this line. The conventional method for border molding was using green stick compound, which involved quite a few steps. Luckily, heavy body has very good consistency for border molding. Alrighty, and I'm going to have you relax everything as I go ahead and place this in. You always want to tell the patients to relax. They're always going to fight you until you tell them to relax. If they're fighting, they're going to give you trouble getting the information you need to make them a good denture. Okay, go ahead and turn my way a little bit and open nice and relaxed. Okay, I'm going to hold the tray up like so, and I'm going to do my border molding. Here I'm grabbing the masseter and pulling forward and down. That forward and down is what dislodges most dentures in the posterior area where the hamular notch is, or the maxillary tuberosity. Now I'm going to come back over to this side and do the same thing. I'm going to have you blow through your nose for me, Ann. Good, good. That captures the vibrating line. And then open as large as you can, and then back down. And then relax. You can relax your jaw now, good. And then the last thing, go ahead and purse your lips. Good, and then relax. All right, so while we're sitting here, I'll go through what those things do. Having the patient open up as wide as they can ensures that the impression on the buccal part of the maxillary tuberosity is not getting interfered by the coronoid process. The coronoid process in some patients is very close to the maxillary tuberosity, and that can cause dislodgement of the denture or create sores. The best time to figure that out is during the impression. So you're telling the lab where is the outer border of the patient's anatomy, meaning where does the coronoid process go, by capturing that in the impression. Number two is the vibrating line. I had the patient blow through their nose while pinching it. That's called the Valsalva maneuver. It activates the internal pressure in the oropharynx to create vibration of that vibrating line to give the lab information on where to put the posterior palatal seal. Very common mistake not captured in removable prosthodontics. Yes, we can use the Thompson marking stick. That is another method. I will use that if I don't see it in the impression. So I want to make sure that when I send this to the lab has the information to place the posterior palatal seal where it needs to be. Otherwise, they're guessing. So you're going to look at the fovea palatini and the hamular notch. All of those areas of information need to be captured for the lab to do what they need to do. But you're also relying on them knowing what they're looking for and then creating a posterior palatal seal. I think it would be a good idea to maybe do that yourself. That removes any of the potential issues. Nothing is more frustrating than a denture not sealing or fitting well. That's one of the biggest reasons. I had the patient do it here even though I wasn't necessarily capturing that. Just by habit, whether or not that PVS material was in that area or not is not really that important, but it is something to consider. Then I had the patient purse their lips to create the anterior vestibular information capture. And then lastly, pulling the masseter down, the buccinator, forward and down. If you ever have a denture that's unstable, pull in that area, and if it dislodges, then put PIP paste up there and trim it back until you are where you need to be. I'm trying to get that information now so that I don't have to do it later. But there are times that despite the fact that we give the lab all of that information, they still send it back too thick or too long. You have to know how to assess for those. Topic for another day, but the motions that you do for border molding are the same motions you do to find out where a denture is potentially impinging. All right.